Dr. Suman, Dr. Venkat, Dr. Gite, sir.
Good evening, sir.
Good evening. We just wait for 5 minutes till the residents they join.
Sir, good evening, sir.
And
Yes,
then-
sir.
Sure, sir.
Huh?
Yes, sir.
Yes,
Good
yes.
evening, Gite, sir.
Yeah.
Yes, good evening. Good
Dr.
evening.
Suman, have you talked to the residents, अपना Saifi residents also, na?
I don't know. I know the previous batch. This batch, I don't know, sir.
Okay, okay. Because I had told Achin to inform all of them in your radiology department.
Okay.
Huh?
Okay, sir.
So, Dr. Gite, any information on DNB practical exams?
Sir, 15th, 16th, second or third week of November, there will be exams.
Okay. And they have come to know that Mumbai Nair is going to be a center.
Initially, they have asked for us, as I am not there, we have rejected. So I will check it out about Nair, sir.
No, the Nadiad people have come to know. They are supposed to come to Nair. I think so. Today, our resident told us that they are getting Nair. So Nair is one center. Then there are some people, I think, if Abhishek is there.
Sir,
Wouldn't
Nair,
be
yes,
there.
sir. All 6 people got Nair center on
There
14th and
are
15th, sir.
definitely there are center in Delhi, Chennai, Kolkata, Mumbai. Definitely one center each place.
Yes, sir. Sir, IKDR and MPUH, all 6 people of both institute got Nair, sir. And IPGMER in Calcutta is one center. AIMS Kochi is one center, sir. And
I know that.
Yes, sir.
Stanley, probably
Stanley, yes,
Stanley
sir.
in Chennai.
Stanley is also one center, and this one, sir, RNR Delhi is one more center.
RNR in
Kolkata.
Delhi. RNR in
Kolkata
Delhi.
also one center is.
Yes. Let it be, don't worry. कहीं पे भी center रहा तो कुछ फर्क नहीं पड़ता है. You have adequate preparation and you should be we should be stuck with basics and should not do any major mistakes or blunders. That is the prerequisite of passing the exam.
Nowadays, even examiners are considerate. They understand.
Very lenient.
So they are
Very,
not
very
there
lenient.
to, they are not there to
if
fail.
you
They are
and me
there
are,
to pass them.
people like you and me are if examiner, then there is no question of failure.
But sometimes what happens, the old time professors, those who have done MCH, they come as an examiner, there will be lots of problems.
So during my examination, in 3 days, 2 people passed. So
Last 2 years, so I think it is 100% result. Almost 100%.
Major
Hardly
mistake
any.
अगर नहीं किया ना सर तो usually पास फेल होने का चांस बहुत कम रहता है.
That's true.
क्योंकि सब हेडिंग्स ही इतने बना दिए हैं डीएनबी में भी कि सब सेक्शंस तो थोड़ा भी मार्क दे दिया तो नियर टू पहुंच जाता है फिर.
But unfortunately now there is no OSCE. OSCE was, I think, one of the good way to compare all the students, and they had a good chance of passing.
लेकिन क्या आप जैसा बोले वैसे का ओल्ड टाइमर आ गया ना then it is slightly difficult. Otherwise कुछ प्रॉब्लम नहीं आएगा. और आप और मैं कहीं ना कहीं तो एग्जामिनर रहेंगे. अभी कहाँ रहेंगे भगवान जाने, लेकिन रहेंगे.
Hopefully, and our students come under us.
वो तो सर अभी उनका नसीब है, अपना नसीब है, उनका नसीब, बस बाकी कुछ. Last time when I was in RNR, the 2 people from Nair has appeared in front of me and both has got good marks.
Yeah.
तो डिपेंड है. लेकिन नायर में आया तो कोई डिफिकल्टी नहीं आएंगे because people know each and every student from Bombay as well as surrounding.
Correct. So we wait for 1 or 2 minutes and then we start. I will just introduce Dr. Suman and then we will start.
SK Singh sir दिख रहे शायद.
Pardon?
SK Singh sir है क्या?
SK Singh, I don't know. 1 second.
हेलो, मुझे लगता है दिख रहे पिक्चर में तो. सर.
Shravan Singh.
Good evening Singh sir.
Is there?
Yeah. Connect हो रहे हैं. हेलो. Good evening Singh sir. Good evening Singh sir.
We'll have to unmute him, no?
No. Hi. He can unmute himself.
Yeah. Good evening, Dr. Gite.
Yes sir. Yes sir.
Yeah,
Just I am talking about the pattern of examination and the type of examiners we encountered in the past. Right. Slight change nowadays.
That's right, sir. Good.
Good evening, SK Singh, sir. Dr. Gaurang Shah.
Good evening, sir. Good evening, sir. Very nice, sir, that you have a program for PG. That's very good.
We are very happy to have you. And now, since you have joined, from next time, I'm not going to leave you. I will send you a message and you'll have to join.
Right, sir. Right, sir. Always, sir.
Your
my
expertise
privilege,
will really help students.
Thank you, sir. That's good, sir. Always for students.
Yeah.
Yes, sir. Always for the science and always for the society, sir.
Yes.
Is always for that. Yes. Dr. Shah, thank you.
So, in 1 minute, we'll start, sir. Because
No problem,
many students, they are DNB, so they are working in. That is why we have kept it little late, 9 o'clock.
That's right. Yeah, so that they can, after their duty, they can join it. Yes, that's
And
good,
now,
sir.
unfortunately, what has happened that most of the MCH exams are over.
Right, and now DNB exam has started from next week, from second week of November, right? Sir.
That's true.
Sir, who will be answering today, sir?
Who is going to answer today?
So,
Sir, I am Abhishek, sir. I'll be answering, sir, today.
sir, I am Ojas, sir.
Okay. So, SK Singh, sir, what we have done is that we have got Dr. Suman Jhangra.
Right,
She
sir.
is, we'll be talking about renal scans, and at the
Right.
end, she will give few scans.
Right.
So they can answer what is the scan showing, what is the diagnosis,
Right.
and what are the different types
That's
of
right.
scans. So she will ask the
Basic concept.
question
Right.
at the end. So that is the
Right.
way we will go ahead. So that
Right. Good.
they will have a theoretical knowledge as well as they will have some practical knowledge
for
how to
practical.
answer
Right.
in the exam.
Right. Right, sir.
And in between, if you have any comment and this thing, you can always tell us. Once the lecture is over and you want to teach the students, whatever you want to say, please tell them. So I will just introduce Dr. Suman. Dr. Suman Jhangra is the head of the Department of Nuclear Medicine, Saifi Hospital. She has done her PG from Tata Hospital, Diplomate Certification Board of Nuclear Cardiology from USA. She is a fellow European Board of Nuclear Medicine. She has specialized in radionuclide therapies for malignancies of thyroid, neuroendocrine tumors, and prostate. Radionuclide metastatic bone pain palliation, she is practicing. So I invite Dr. Suman Jhangra. She can share her screen and she can start.
Thank you so much, sir, for inviting me. So can you see the screen?
Yeah, we can.
Yeah, we can see.
Yeah. Good evening, everyone. I am going to talk on the applications of nuclear medicine in urology, right from diagnosis to its applications in therapy. When we talk of nuclear medicine, when we talk of any conventional radiological modalities, what we basically do in conventional modalities is we assess the structure of any organ, right? When you talk of sonography, they will tell you about how the what is the size of the organ, how it is looking like. But when you talk of nuclear medicine, it is a functional imaging modality. So in any scans of nuclear medicine, we basically assess the function of every organ so that we have a pathology matched functional information. Okay. Now for having this functional information, what we do is we have organ specific radioisotope compounds. We utilize the physiology of the body to assess the physiological function of that organ. Now, since we are talking about the urological system over here, the radioactive compounds which are selected are such that which are taken up by the kidneys and are excreted into the ureter through the urinary bladder so that we can assess the physiology of the kidneys. So rather than the conventional modalities, which are more of the structural imaging modalities, nuclear medicine is a functional imaging modalities. And because it is a functional modality, the images or the information that we give is a reliable and a reproducible information. And the advantage of this, because of these advantages, eventually it has become very important aspect in the diagnosis as well as in the management follow-up of the patient with the urological problems. I have divided the lecture in two parts where in the first part, I'm going to talk on the applications of nuclear medicine in the benign urological pathologies. Before I go into that, when we talk of the kidney, when we go on the structural aspect of it, on any structural imaging modality, what you will have in the reports is like the renal cortex, like whether the corticomedullary differentiation is maintained or not, whether cortical thickness is maintained or not. So that is about the structure. But when we come to the functional information, what is the functional unit of a kidney is a nephron. So what we do in nuclear medicine is we study the functional assessment of it. Now in a nephron, if you look at the right hand side, the parts of a nephron are you have a glomerulus, you have the proximal convoluted tubule, and you have a distal convoluted tubule. These are localized in the renal cortex, and you have the loop of Henle and the collecting system, which are localized in the renal medulla. Now, taking a brief overview on what are the imaging modalities that we use for urological diseases. First and foremost, the first modality of choice is ultrasonography. And based on what are the ultrasonographic findings, the patient is subjected to either an IVU, IVP or a CT KUB. The other investigation is an MRI and an isotope renogram. Now let's get familiar with what are the common terminologies that are used in the reports. When you talk of an X-ray, either it is a radio opaque or a radiolucent based on whether the X-rays can pass through them or not. When you talk of a USG report, what you will usually see in the reports is whether the echogenicity is maintained or not. So either it is hyperechoic or a hypoechoic. When you talk of CT, whether it is about the density of the lesion, whether it is a hyperdense or it is a hypodense. In MRI, they will talk about hyperattenuating or hypoattenuating signal intensities. When we talk of nuclear medicine, here we are injecting the radioisotope, which is taken up by the kidneys and excreted out. Usually the nuclear medicine reports will have terms like uptakes, whether the radiotracer uptake is normal, high or low. This is a classical picture of a plain X-ray KUB. In solitary, it actually does not serve any purpose other than if there are radio-opaque detection of radio-opaque calculi. The only advantage is that it is cheap and it is usually easily available. The radiation exposure that you usually get from a plain X-ray KUB is around 1 millisievert. This is just an example where there is a detection of the radio-opaque calculus in the lower pole calyces of the right kidney. Now, the radiography has a sensitivity of 62% and a specificity of 75% for detecting the stones. Now, other than the stones, it does not give you any further information about the urological system. Now, one step ahead of it is an IVU, where up with the plain X-ray IVP, there is a contrast which is injected intravenously, and then you have a nephrogram phase and an excretory phase where you can delineate the kidneys, the calysis, and the movement of radiotracer into the ureters, into the bladder. Again, it is a cheap modality, but however, it at least gives a one step further information about the urological system. Now, the radiation exposure from an IVP is usually 3 millisievert. Ultrasonography is the first modality of choice. The advantages are it is easily available. It is a cheap modality. There is no radiation exposure is involved into this modality. And it is based on the high frequency sound wave, which is sent across the body. And there is a contrast between the tissue, so which is determined by the sound reflection. It is usually precise for trauma, stones, tumors, and infections. Now, CT-KUB is the latest modality that is there, which is used in diagnosis of various diseases of urological system. This is again, you have a plain CT-KUB, then you inject a contrast intravenously, and then you monitor the movement of contrast by taking serial CTs. This is a nephrogram phase with movement of contrast into the ureter and into the urinary bladder. So you can diagnose all the anatomical distortions like a stricture, you have dilatation of PC system, your thinning of cortex, ureterocele, or any anatomical distortions will be easily identified on a CT-KUB. The disadvantage here is the patient needs for the fasting, the patient needs bowel preparation, and also if there is any history of contrast allergy, because you're using iodinated contrast, so you cannot use contrast in those patients. And on top of it, the radiation exposure from a CT-KUB is to the level of 20 millisievert. Now, when we come to nuclear medicine, it does not require any fasting, no bowel preparation is needed. Because there is a functional assessment, the only important preparation is that the patient needs to be well hydrated for it. It is a non-invasive modality. It gives good functional as well as anatomical information. And as we all know that before the structural distortions happen, it is usually the function which first gets affected. So nuclear medicine investigations help in early detection of disease even before the structural changes become prominent. And in addition to this, the nuclear medicine investigation specifically in urological system gives rise to a radiation exposure to the level of only 2 millisievert. So all these advantages, characteristics have contributed to its a significant and widespread use in, and the information it provides. It has become the modality of choice in diagnosis as well as the management of various urological diseases. Now, when we talk of the nuclear medicine investigation and urological system, it is very important to first understand what is it that we want to study. Now, on the left-hand side, if you see, this is the parts of the glomerulus. So whether you want to study the glomerular function, or you want to the tubular function, or you want to assess the vascularity, we need to know that first before we actually choose the agent for assessing the function of the kidney, because there are various isotopes which are targeting the specific function of a kidney. So now if your clinical question is that you want to assess the perfusion of the kidneys, like in cases where there is renal artery stenosis, the agent of choice would be either a DTPA, which I think EDTPA, or EC, which I think most of us are aware of. Now, if you want to study the morphology of the kidney, like in cases where there is recurrent UTI and you want to understand if there is any cortical scarring, then DMSA is the agent of choice. Now, if you want to see whether the system is, or there is any obstruction in the system or not, either DTPA, EC, MAC3, all three can be used to assess the obstruction. MAC3 is a very good agent. However, there are constraints on its availability in India. Now, if you want to understand the differential function, like in cases like donors, or if there is a suspicion that there is a non-functioning kidney, you want to understand the differential function, it can be assessed by any of these agents. Now, if you specifically want a GFR estimation like those of donor evaluation, you need to do a DTPA renogram, because that is the only agent which will give you a correct estimation of the GFR. Now, when we do a renogram, whether it is DTPA or EC, what we will be able to assess is we will be able to assess the renal perfusion. We will be able to estimate the parenchymal function, GFR in cases of DTPA, or ERPF in cases of EC renogram, differential function, and the drainage pattern. Patient preparation I've told, but the only thing is important here is that the patient is asked to avoid before we do the study to avoid the back pressure effect of full bladder on the excretory part of the kidneys. Now, what are the indications where we can use a dynamic renal scintigraphy or an isotope renogram, which is commonly termed as antenatal cases of hydronephrosis, to understand whether there is any obstruction to the urinary tract outflow, in identification of hemodynamic significance of the renal artery stenosis or in cases of renovascular hypertension. Now, pre-surgical quantification of the renal function in cases who are like subjected to nephrectomy for renal masses. In renal transplantation, whether it is donor assessment for evaluation of the donor kidney function or the recipient assessment for the post-transplant complications. Now, I won't go into this, but the important points in this are unlike CT KUB, where the contrast is injected and the CTs are taken at intervals. In nuclear medicine, the whole transit of radiotracer right from the time of injection to its excretion into the urinary bladder is captured. So it is a dynamic process where the image acquisition starts immediately after injecting into the vein. And here the images are acquired in posterior view because the kidneys are located posteriorly. So when I show you the images, whatever is on your right is the right kidney and whatever is on your left is the left kidney. Now, whenever we inject the radiotracer into the vein, it goes into central circulation and then it goes into the abdominal aorta. Through the abdominal aorta, it will go into the renal veins. This is a sample picture of perfusion image, where if you look first, it goes into the systemic circulation, it goes into the abdominal aorta, and then you start seeing the kidneys. So this phase helps us in assessing the perfusion of individual kidneys, whether there is any compromise in perfusion phase to any of the kidneys. Now, once it goes into the circulation, there is first pass extraction into the kidneys. So there is a gradual increase in the extraction of tracer by the kidneys. Then from the kidneys, then it gets excreted into the ureter and then into the urinary bladder. Now, if you look at this, it goes through the kidneys into the species system, into the ureters and the bladder. So by the end of the study, you will have only in the bladder with very faint visualization of kidneys. Now, that was the qualitative assessment of your renogram. But the important part of it is there is a quantitative information that is always provided with a renogram curve. Now, how this renogram curve is generated is when it starts going into the kidneys, the ROIs are drawn over the kidneys. And then when these ROIs are drawn, a time activity curve is generated over here. Okay, based on how it moves into the kidney. So this is your perfusion phase. Then it gradually builds up into the kidneys. So one important parameter that we give in our renogram report is your time to peak, that is T max activity. So it is the time taken for the radiotracer to reach its peak activity. Usually in normal kidneys, it is less than 5 minutes. Then gradually it goes into the PC system, into the ureter, and gradually the curve comes down because very little activity remains in the kidney. So the second quantitative parameter that is given in the reports is your T half time. That means the activity is half compared to what it was maximum, in what time it has become half. So in normal kidneys, it is usually less than 10 minutes. The third parameter that we give, usually not given, but many a time based on how the excretory curve is, the third parameter is your cortical retention at the end of 30 minutes, which is usually in normal kidneys, it is less than 30 minutes. And the last and most important is your split function. How much is the individual kidney contributing towards the total renal function? Now, this is how a normal renogram image looks like. So this is the image where you have drawn the ROIs to get the quantitative data. These are your renogram curves. This part is your how you get your perfusion, whether the perfusion to individual kidney is normal or it is reduced. This set of images are the parenchymal images where it is taken up in the kidneys, goes out into the ureters and into the bladder. So if you see at the end of the study, you see this is the starting of the study. This is the end of the study. If you look, the entire activity which was there in the kidneys is now in the bladder. Bladder here was hardly seen. Now, if you see, the whole activity is in the bladder here. Now, if you look at the quantitative data over here, you have information like you have split function. So your left kidney contribution is 52.5% and your right kidney contribution is 47.5%. GFR value, which is 44.3 on the left side and 40.1 on the right side. Usually we take individual kidney 40 as a normal range. Then you have time T half, which is 6 minutes on the left hand side and 6.8 minutes on the right hand side. So if I go back, this was a normal renogram curve, or we call it as a type 1 curve over here. Now there is another condition where gradually the radio tracer will build up. However, there is no downfall over here. So in such cases, we use a diuretic intervention. Okay. Diuretic intervention is used to increase the urinary flow. So there are various protocols which are followed by the nuclear medicine physicians, whether it is F+10 protocol, where it is injected 10 minutes after the radio tracer injection, or it is F-15 protocol, where it is injected 15 minutes before your radio tracer injection, or if it is F0, where it is injected with radio tracer injection. Yeah, each nuclear medicine physician uses as per their choice, but however, I prefer to use an F+10 protocol because your renal function assessment happens in the first 2 to 3 minutes. So the whole system is under normal physiological conditions. So you get a physiological GFR values under physiological conditions. So that is why I prefer F+10 protocol. So now in this curve, if you see, even after the diuretic intervention, the curve continues to remain the straight line ahead and it does not fall down. This curve is a characteristic of an obstructive system, obstructive pattern curve. Now, this is a third type of curve where there is a gradual buildup of radioactivity, but the moment I give diuretic, there is a sharp fall because of excretion of radio tracer. So this is a pattern where we see where there is the system is dilated, but there is no mechanical obstruction. It is a functional dilatation of system. So because of functional dilatation, the radio tracer keeps on pooling in the dilated PC system. However, where I give a diuretic to increase the urine flow, because of increased urinary flow, it goes out of the system. Now, this is another pattern which we very frequently encounter is your dilated system. So the radio tracer keeps on accumulating. After we inject a diuretic, it does fall, but it does not fall to a significant limit to call us that it is non-obstructed. Neither it remains a straight line to call it as an obstruction. So this pattern is called as an equivocal curve. There are various reasons which I will show you in the later pictures. Now let's go to the case series. Now this is a case of a 3-month-old female who was antenatally diagnosed with right hydronephrosis. Postnatal USG showed moderate right hydronephrosis with a pelvis AP diameter of 1.5 centimeters. Now serum creatinine was 0.6 milligrams per DL. Now I have shown you all the segments of the images in previously. So now if you look at perfusion images, would somebody like to comment?
Yes, ma'am.
Yes.
Ma'am, the perfusion appears to be adequate on both sides, ma'am. Although on the graph, on the right side, on the left side, the perfusion is reduced. The peak of perfusion is reduced on the left side, ma'am. And on the right side, the peak appears to be appearing at a delayed time.
Okay. See, basically, these are not perfusion peaks. These are cortical uptake phase peaks. Okay. So if you look at perfusion images, more or less perfusion is preserved. If you look at the cortical function, this is the left side where there is good uptake and goes out into the PC system, goes out through the ureter into the urinary bladder. Your red curve is your left kidney curve. Okay. It goes up. Your T max, if you see over here, your T max is 4 minutes. Okay. And it goes out. So this is your normal renogram curve. Now, if you look at the green curve, which is the curve for the right kidney, the PC system is dilated. So there is a gradual hold up and pooling into the PC system. I inject diuretic at 10 minutes and then it gets washed off. See, this is 10 minutes where I've injected Lasix, and at end of the study, if you see the entire tracer which was there in the PC system is gone out. Okay, so this is a characteristic, typical textbook picture of non-obstructive right hydronephrosis. So as I told you, whatever you see on the right hand side is right kidney, whatever kidney you see on your left is left kidney. Okay.
Okay.
So characteristic pattern of a non-obstructive functionally dilated system. Now let's go on to case 2. It's a 45-year-old male presented with right flank pain. On sonography, there was moderate to severe right hydronephrosis, PUJ obstruction, suspicious of PUJ obstruction. Also, there was thinning of cortex. The serum creatinine here was 1 milligrams per dl. Now, would somebody else want to comment on this?
Yes, ma'am. Ma'am, on the actually,
These are
yeah,
perfusion
on the,
images. So
yeah,
first thing that we have to comment is on the
right side.
perfusion.
But on the perfusion, right side, the perfusion is decreased.
Yes.
The right side, there is no uptake only as such. We can't see any right side uptake.
Correct.
On the parenchymal images, the left side drains adequately, but whereas we can see that on the right hand side there is delayed actually uptake seen in the later part of the images.
Correct.
So
if,
showing that the right sided system. Yes, ma'am.
correct. So if you look at the left kidney, normal perfusion. If you look at the cortical uptake phase, it is taking up well and it is draining off well. There is no retention seen here. If you look at the curve, your T
Type
peak
2
is
curve.
at 4 minutes and your T half, your curve comes down. So your left side is absolutely normal. If you look at your right kidney, in the perfusion images, you hardly see right kidney. So your perfusion is grossly reduced. If you look at the cortical images, see, you don't see the renal parenchyma like you see on the left-hand side. That is because of your thinning of cortex. Gradually, it takes up the radio tracer, and then all what you see over here is your dilated PC system. So because of dilated PC system, it keeps on accumulating over here. And in spite of diuretic intervention at 10 minutes, the curve continues to rise. Correct? It is a typical characteristic pattern of an obstructive system. Now, the other thing that we look at is your differential function over here. If you look at the differential function, normal variation that we take acceptable as a normal is 45-55. Now, if you look at the function, the differential function of your right kidney, it is 35.66%. So, which matches with the compromised function of your right kidney because of your thinned out cortex, back pressure effect of obstruction, your cortex is thinned out and it has gone to a stage where the renal cortical function has started to get compromised. Okay. So this is your characteristic obstructive pattern curve. Now let's go to the third case where again there is a right-sided PUJ obstruction. But in this case, if you look at it, there is a preserved cortical function. Because if you look at perfusion images, this is your dilated PC system, but this is your renal cortex. If you look at your renal cortex, the perfusion appears to be preserved. Your cortical uptake appears to be preserved. However, gradually, if you see there is buildup of activity in the dilated PC system, and in spite of diuretic intervention, the curve continues to rise, and there is hardly any fall. Now, this fall, what you see is, if you see the ROI, I include only the cortex. I don't include the PC system. Correct? So whenever this is because it has gone into the dilated PC system. That is why the counts come down. So the curve falls a little, but do not it doesn't excrete so much. So it is falling to a very small level. Characteristic of again obstruction. But in this case, the cortical function is still preserved. So in cases of obstructive uropathy, what is the information that we get from the scan is it helps in evaluating the functional significance of hydronephrosis. Okay, so on structural modalities like your CT will be able to tell you about the stricture and all, but not the grade of obstruction. On sonography, they will tell you about the hydronephrosis, but what is the functional significance of hydronephrosis, whether there is any obstruction to drainage or not, whether it helps in determining the need of surgery, because if it is an obstructive hydronephrosis, surgical management is the modality. If it is a non-obstructive hydronephrosis, the patient needs medical therapy or follow-up. It also helps in monitoring the effect of therapy. Now, I will show you a case where this was a renogram parenchymal phase only I have taken, where if you see the left side is obstructed, if you see your right has drained off, the left kidney is obstructed. The patient underwent, if you see the curves also, this was an obstructive pattern curve. The patient underwent pyeloplasty, and post-pyeloplasty, if you see the renogram curve, there is improvement. So usually there is a variable phase. Even if you want to do a follow-up, it is not necessary that every patient will demonstrate an improvement in the renogram curves or the drainage pattern. Functional improvement will come immediately even after relieving the obstruction. The drainage pattern may remain impaired for a variable time. Some patients may show improvement in drainage at 3 months itself. Some may take 6 months, some may go even after 1 year. But what we need to monitor in such cases is your cortical function, which gradually improves and remains stable or remains stable. It does not deteriorate. So in obstructive uropathies, you get meaningful information whether their obstruction is significant or not. It is supplemented by the clinical and the ultrasound or the structural modality information and helps in ultimately assessment whether the patient needs surgery or just the conservative management. Now, second very important application where we use an isotope renogram is the renovascular hypertension. Now, what exactly is or renovascular hypertension is? It refers to hypertension which is caused by the renal reduced blood supply to the kidneys, that is renal hypoperfusion. Usually the most common cause is the renal artery stenosis. Now, the mere presence of renal artery stenosis does not mean there is renovascular hypertension. Most of the times it is just an incidental finding. But in such cases where you have a finding of renal artery stenosis, but the patient also has hypertension. So whether you need to understand whether the hypertension that the patient has is because of the renal artery stenosis or it is just an essential hypertension. So to assess this significance of whether this hypertension is because of renal artery stenosis, you need to first understand what is the pathophysiology of renovascular hypertension. Now, if you see this is your glomerulus. You have an afferent arteriole, you have your efferent arteriole, and this is your glomeruli. Now, what happens if there is a renal artery stenosis? Does anybody know renin-angiotensin system? Okay. What happens is if there is a renal vascular stenosis, so your blood supply to the kidney is reduced, right? So you have the afferent arteriole, your blood supply through the afferent arteriole into the glomerulus is reduced. So if this happens, what happens is your juxtaglomerular apparatus, it secretes renin. Okay, the renin will act on the angiotensinogen and it will break it down to angiotensin 1. Now, angiotensin 1 is inactive molecule. So it is activated by angiotensin convertase enzyme, okay, ACE, and it is converted to angiotensin 2. Now, angiotensin 2 acts on the efferent arteriole and it causes vasoconstriction of efferent arteriole. So earlier, what was the cases if only afferent arteriole was constricted? So because of which there was fall in pressure in the glomerulus because of decreased blood supply. Now, what angiotensin 2 does is it causes efferent arterial constriction also. So your pressure in the glomerulus is maintained. So that is a physiology of what happens in renal artery stenosis. Okay, the afferent arteriole, your efferent arteriole, you have a normal GFR in normal kidney. In cases of renal artery stenosis, angiotensin 2 causes vasoconstriction, maintains the glomerular pressure so that your GFR is maintained. Now, what happens in what we do is there is something called as a captopril renography or an ACE inhibitor renography. Earlier, it was called as captopril renography, but now the captopril is banned. So we use ACE inhibitor enalapril. Okay. Now, what ACE inhibitor does is it blocks the conversion of angiotensin 1 to angiotensin 2. Okay. So by blocking this, angiotensin 2 is not able to cause your efferent arterial constriction. Now, what will happen if there is no constriction of efferent arteriole? There is drop of perfusion pressure here. Now, what will happen with drop of perfusion pressure is your GFR is reduced. Okay. So now in captopril renal scintigraphy, what we do is we first do a baseline scintigraphy to assess what is the baseline renal function. What is the baseline GFR value? At baseline, if there is any renal decrease in blood supply of the kidney, what is the basic parameters that we assess in a what I showed you in a renogram? All basic parameters are assessed in a baseline renogram. Now, the second part of the study is the post-ACE inhibitor study where we inject ACE inhibitor. This is your baseline renogram where both the kidneys pattern curve, if you see, it is normal, uptake is normal, excretion phase is normal. The second study is you inject ACE inhibitor and 10 minutes after injecting the ACE inhibitor, we again repeat the same renogram, but this time after inhibitor. So what this ACE inhibitor will do is it will block your efferent arterial vasoconstriction. So it will reduce your GFR value. Now there are various parameters that are laid up. Okay. on ACE inhibitor for detecting. One is your change in renogram curve. Now, if you look at the renogram curve of your right kidney here, it is like a normal pattern. If you look in the post inhibitor, has it changed?
Yes,
Okay.
ma'am.
So change in grade of renogram curve. Okay, that is the first criteria. Now, if you look at the second criteria, time to peak. Okay. Now look at the time to peak over here, correct? And look at the time to peak over here. So usually the delay in time to peak of more than 2 minutes is second criteria. Now, if you look at the third minute, increase cortical retention at 20 minutes or 30 minutes by change of it by 40. Now, if you look at the retention at 30 minutes or 20 minutes over here, and you see it over here, is there increased retention?
Yes.
Correct?
Yes, ma'am, on the right side.
Fourth is your visualization of PC system. Because of increased retention, if you look, your PC system here is visualized in the second frame, correct? It is into your proximal dilated system, and then it will go into the ureter. But you start visualizing your PC system activity in the second frame. You look at over here, is there a delay in visualization? Correct?
Yes, ma'am.
Okay. Now last is your split function. Now, because of this, there is because of the fall in GFR, correct? Because there is loss of efferent arterial vasoconstriction, your GFR will fall. So your individual split differential function, which we calculate, there is a fall in differential function of more than 10% of the affected kidney. Now, if any of the 2 out of these parameters criteria are positive, that means the hypertension that the patient has is because of is a renovascular hypertension, and your correction of renal artery stenosis is going to be beneficial for the patient. However, if by doing the second part of the study, if there is no change in any of the parameters, it is negative study. Even if you correct the renal artery stenosis, the hypertension is still going to be there. It is not going to get changed because the cause of hypertension is not renal artery stenosis. So this is a very important application where we understand and assess whether the renal artery stenosis, hemodynamical significance of renal artery stenosis, whether that is the etiology for hypertension in the patient. Okay. Now, sensitivity for detection of renal artery stenosis is 51%, but the specificity, if you look at it, is 96%. So if we say that it is hemodynamically significant and it is the cause of renovascular hypertension, the correction of renal artery stenosis is definitely going to benefit the patient. The only disadvantage is what if we are talking about is if there is a bilateral renal artery stenosis. Now, if there is a bilateral artery stenosis and if I give ACE inhibitor, both the kidney function is going to go down, correct? So individual, the relative differentiation that we as a criteria that we have set is difficult to understand. Also, if your renal function is already severely compromised, so if there is a differential function of 10%, if 10% becomes 12% or 8%, the degree variability is very difficult, is not very reliable because the percentage function itself is very, very low. Third thing is if the patient has chronic urinary obstruction, you already PC system is dilated. Already there will be a retention of radioactivity. In such cases, whatever criteria that we have set for in diagnosing the renal artery stenosis, usually it become unreliable because there is already tracer activity in your dilated PC system. Okay. Now, the third very important application, though underutilized, is the reflux nephropathy. Now, what is the modality that is most commonly used to assess the reflux?
VCUG, ma'am.
Yeah. So when we talk of reflux, this is a normal system where there is a wall at the terminal end of the ureter. It is a unidirectional wall. Now, because the wall is dysfunctional, there is a retrograde movement of the urine into the ureters, and based on what is the grade of reflux, it may go up to the cheilitis and then start impairing the cortical function. This is the most commonly MCU that is used, which is a picture which shows the reflux of grade 4 into the left side, correct, with the presence of a uterociliar. Now, what the radiation exposure in a MCU is to the level of 1.2 to 1.5 millisievert. Now, how we do VUR? Now, in MCU, how do you do MCU? If anybody knows. See, in MCU, basically, you try to fill the bladder with the...
Abhishek,
Yes, sir.
you can answer this, please.
Yes, ma'am. Yes, sir. So, ma'am, in the MCU, ma'am, with the baby in supine position, ma'am, the bladder is filled with contrast.
Correct.
And if the child is young, ma'am, because of primitive micturition reflex, the baby voids once the bladder is full. And at that time, ma'am, the films are taken and the MCU is taken. I mean, some centers, ma'am, the urethra is also assessed along with during the bladder filling. So an RGU is also done. That is, ma'am.
Correct. So what we do in nuclear medicine is more or less same, but the difference is you take, make the bladder full using your dye, and then you capture the images when asking while the patient is micturating, correct? Now,
Yes, ma'am.
in reflux study by nuclear medicine, we also fill the bladder, but in this cases, as I said in renogram, the whole filling of bladder and emptying of bladder is captured in a dynamic system. From the time we start filling up the bladder to the time bladder gets empty, the whole process is captured under the camera. Now, why it is important is what MCU does not give is at what volume during the filling phase, if there was a reflux, at what volume the system starts refluxing. Suppose you have a patient where the estimated bladder volume is around 300 ml. We start filling up the bladder. Same two patients I have. In one patient, the patient's reflux starts at 50 ml. The other patient may start at 200 ml. Correct? It has its own physiological significance. Like the person whose capacity of bladder is 300 ml, but starts refluxing even when the bladder is 50 ml full. So at what bladder capacity the system starts refluxing, or if at all there is any reflux during the filling phase of the bladder, then you have an emptying phase of the bladder where the patient voids also in front of the camera, and at what volume of bladder again we can't detect what volume it starts refluxing during the emptying phase, but during the emptying phase, it's whether it starts refluxing or not. This process is a direct VUR study. Now, but if you look at our DTPA renogram also, during the study, the whole activity now ultimately goes into the bladder, correct?
Yes.
So we can also assess the reflux as a part of DTPA renogram by asking the patient to just void in front of the camera, under the camera, correct? So along with DTPA renogram, if there are cases like suppose the ureter is also dilated and the clinical suspicion is of a VUR, we can also assess VUR in the same study by asking the patient to void under the camera. But in such cases, we can only capture the voiding phase. Here, because the bladder is not filled according to the bladder capacity, it is as a part of the DTPA renogram. So direct I have explained you, indirect I have explained you. This is an example of direct VUR study where during the filling phase, there is a reflux, and it is a grade 4 because it is going up to the renal pelvic calyces. Okay. Now, this is a part of indirect VUR where this is the last frame of a DTPA renogram where the entire kidneys have drained into the urinary bladder, and I ask the patient to void under the camera. You can see on the left-hand side, there is a grade 4 reflux. So either it can be a dedicated VUR study, which is a direct VUR study, or it may be a part of DTPA renogram, which we call it as an indirect VUR study. Now, this was about your assessment of perfusion, assessment of renal function, assessment of the drainage system. Now, suppose you are more important, what your interest is, whether there is about the morphology, whether there is any renal scarring post in patients who have repeated episodes of UTI. In such cases, as I told before, your radiopharmaceutical of choice is your technetium 99M DMSA. So you will prescribe a DMSA renal scan over here. Now, why DMSA is because it is a tubular agent. Once we inject DMSA, it gets attached to the tubules, okay, which is there, and it takes some time for getting it fixed into the tubule. So, like DTPA, when we start the imaging immediately after we inject. But in DMSA, because it has to get fixed to the cortex, there is a waiting period of around 2 hours for the DMSA to get fixed to the cortex. So the imaging happens at least 2 hours after the injection, so that the entire thing is fixed into the cortex and also there is no background activity seen. Now this is how a normal DMSA scan looks like. These are your both kidneys. These are on your posterior image. Your right side is right, on your left side is left. Now on a DMSA scan, you can assess about the size of the kidneys. You can assess about based on how is the function also, what is the functioning mass, and whether there are any cortical defects. Now, how does a cortical defect look like? If you follow the renal contour, you can, it is a smooth renal contour, correct?
Yes,
Now,
ma'am.
yeah, now I'll show you a case where we use DMSA renal scan. It's a case of a 2-month-old male child who had history of recurrent UTI. On sonography, there was a left moderate hydronephrosis. MCU showed grade 4 VUR. The other picture that I showed you of MCU was the same patient. Now, this is the picture of a DMSA scan of this patient. Now, if you look at the picture, what is the first thing, even if you don't know nuclear medicine, I think you will be able to tell now.
The
If you look
kidney
at
on
the
the
right
left.
kidney, your right kidney looks normal, right? You can
Yeah.
see the
Yes,
right
ma'am.
kidney well. If you look at the size, more or it is looks normal. If you follow the renal contour, more or less it is preserved, correct? So this is your right kidney, which is normal. But if you go on your left hand side, do you think the size is normal?
Small, ma'am.
No.
Small
It
contraction.
is small.
Small contract.
Now, if you look at the intensity of this black, see the intensity here and see the intensity here, which is reflective of the function. So if you function, it is the functioning mass is reduced over here. And usually because of repeated episodes of UTI, there is cortical scarring which happens, because of which the kidney gets shrunk, and that is why small side contracted left kidney is seen over here. Now, would anybody like to comment on this? Although I have written the diagnosis, but still.
Both sides, the kidney looks to be reduced in size,
Correct.
reduced function, more on the this is anterior, no? So sorry.
Always
There
look
appears to
the
be scarring on both the kidneys.
caries on both sides, and there is more on the left hand side, more on the left hand side.
Okay. Now, if you look at the background over here, correct? You see only the kidneys. You don't see anything other than the kidneys and a little bit of urinary bladder. But if you look at this patient, in this, you see the other background activity also. This
Yes,
is
ma'am.
indirectly reflective of the compromised total function. Okay. Now, if you look at the renal outline over here, it proper bean-shaped kidneys, correct? And if you look
Yes.
at this, is a characteristic cortical scar. Cortical based wedge shaped defects. These are characteristic cortical scars. So in this patient, there is bilateral cortical defects. Usually when it is the first report, you will always see mention it as cortical defect rather than a cortical scar. Because for us to say cortical scar, we need at least 2 scans, because even a pyelonephritis, acute pyelonephritis is going to give you a defect like this, which gradually recovered after antibiotics. But if it is persistent on second scan, then we know it is for a scar. But only on one imaging, we usually don't comment it as a scar. We usually comment it as a defect. Now, spot diagnosis.
Horseshoe kidney.
Horseshoe kidney.
Correct. See, horseshoe kidney, why a DMSA scan is usually prescribed is because of altered anatomy. Even the drainage usually many a times, or the ureteric openings are also altered. So many a times the horseshoe kidneys are usually associated with the reflux. So whether there are any cortical scarring or not, more the DMSA scan is more sensitive and specific for cortical scarring even than sonography. So if you look at these, you can see both moieties of horseshoe kidney outline. If you see, very regular.
Appear
If
to
you
be
see the
regular.
intensity, if the function wise, if you see, it is also normal. So there are no cortical defects in this horseshoe shaped kidneys. Okay. Although there are repeated UTIs, it has still not affected the kidneys over here. Now, other frequently encountered problem is your single kidney, correct? Most of the times, and as an incidental finding, only one kidney is seen, the other kidney may be absent in the renal fossa. Again, a spot diag. In this, if such a picture, if your history is not given, what will you say? If suppose the history is not this, whatever I have written, if the history is not there and this picture is there in front of you, what would be the diagnosis?
Perfusion of left kidney is
No perfusion and DMSA.
okay.
It is only cortex. We don't assess any other thing other than the morphology over here. Cortical scarring is the only thing. Cortical function is the only thing. Two parameters that we assess in this: cortical function, your cortical scarring, and your differential function. So first thing is whether you see one kidney or two kidney.
Only one kidney, ma'am. So
So your
left
father
renal
kidney-
agenesis.
Okay, so on whatever is seen, one kidney, whether it is normal or abnormal.
One kidney appears normal, ma'am.
Correct. So you have only one kidney which is normally functioning with no cortical defects, correct? So the
Yes,
other
ma'am.
kidney which is not there, either it is absent or it is not functioning. If I don't have a history, correct? Now in the case where I have given a history where it is absent, that means it is absent. It is not present in the ectopic location also, because the DMSA is a highly specific agent for renal cortex. So if you don't see other kidney, that means it is not present only anywhere. Even in ectopic location, it is not present. Okay.
Ma'am, if the left side kidney is not seen, ma'am, can it mean that the tracer is not reaching the left side kidney only, ma'am, in DMSA?
See, that is what I told you. If you don't have a history, if you don't see the left side kidney, either it is not functioning, correct? Your functional, what is the functional unit of kidney? I told you it is
Nephron.
a nephron. Your nephrons are dead.
Yes.
Is DMSA going to go there?
No, ma'am.
No. So to what extent your kidney is functioning, how many nephrons are actually viable? Because only viable nephrons are going to take up DMSA. So to what extent your kidney function has gone down because of repeated episodes of UTI or reflux? That is why we do a DMSA scan. If your modality, that is why the first slide which I showed you is what are you interested in? Is your interest the obstruction or is your interest scarring? Okay, because the modality of choice is different for both of them. If my clinical question is cortical scarring, I will go for a DMSA. I will not get perfusion in that. I will not get drainage in that. I am going to get what is the degree of cortical function, differential function, and whether the kidney function, whether the kidneys have any cortical scars or not. If my clinical question of interest is whether there is a system is obstructed or not, if there is hydronephrosis, I will not do a DMSA scan. I will do a DTPA renogram because DTPA or EC because I want to understand whether the system is obstructed or not. Correct? Now, suppose, so based on what is your clinical question, you will choose a radio tracer or you will choose that investigation and send the patient. Okay?
Right, ma'am.
So this is another example. Now, would anybody want to comment on this? Please do not read the diagnosis because these are already prepared slides by me. Without reading, if anybody can tell.
Ectopic right-sided kidney, left-sided kidney is normal. Ectopically located right-sided kidney.
Did you say this after reading the diagnosis? Or
Ma'am, I would say, ma'am, the right side kidney is absent. The left side kidney is in its place. It appears regular in shape without any defects. And there is some amount of background activity. So yes, ma'am, that is what I can make out without reading the.
Now, if I look at this image, this kidney, everybody agrees this is normal.
Yes, ma'am.
Okay, this is posterior image. So this is your left kidney. So left kidney is absolutely normal. Now, in your right renal fossa, do you see anything?
Nothing.
Nothing. So kidney, even if it is present or not present, either it is a non-functioning kidney or it is an ectopic kidney, correct? Two IDDs are there. Now, if you look at this image, I have told you DMSA is a very specific agent for renal cortex. Okay. Now, if you look at the anterior image over here, this is your urinary bladder. Okay. So if you see something over here, it has to be kidney there because you don't see any other structure in a DMSA renal scan. What you see has to be kidney or bladder, nothing else. So if you see something over here, it is your ectopic right kidney in the right iliac fossa or the right pelvis. Now, in its ectopically location also, if you look, there are cortical defects, correct? The outline is not preserved. You have multiple cortical defects over here. So the diagnosis over here is your ectopically located right kidney with multiple cortical defects.
Okay.
See, if there was the bladder was not seen, then I understand your query that probably this may be bladder. But there are various ways in which we can just play with the intensity and identify, because if here based on this intensity you don't see the body outline, correct? But you can make the intensity dark, see the body outline to understand this is a urinary bladder activity, this is activity in the diaper, this is the ectopic kidney. Okay.
Okay.
Now, in a clinical scenario, many a time we have seen that the patient has a multicystic dysplastic kidney, correct? DMSA is very, very helpful here because it helps in assessment of whether the functioning cortex is there in the multicystic kidney or not. Correct? Now, what would you comment on this? See, this is your right and this is your left. So, in this multicystic dysplastic kidney on your left hand side, do you see any functioning cortex on a DMSA?
No, ma'am.
Left hand side, no function.
No function.
Left.
That means it is a non-functioning multicystic dysplastic kidney. So whatever information that is provided on a DMSA scan has to be correlated with your clinical findings. Because if I don't know, so I don't have a sonography to say that the kidney is multicystic or it is ectopic or it is absent, I would just give a DD that your left hand kidney is either absent or it is non-functioning, because I don't know the history. You have the history, you can correlate it accordingly and know your diagnosis, what it is. Why I told you that we don't mention scarring at the first step is if this is a characteristic picture of acute pyelonephritis. Okay, this patient underwent DMSA scan. There is a cortical defect in the left upper pole. Okay, the patient underwent a course of antibiotics. This was a follow-up scan after 3 months. If you see, this defect has resolved.
Yes, ma'am.
Correct. So this was not a scar, but this was just a cortical defect because of acute pyelonephritis. However, if after 3 months also I would have seen the same defect, then it is definitely a scar. Okay. So if somebody is undergoing a first scan, we will report it as cortical defect. And if it is subsequent also we see it, then it is cortical scarring.
Yes.
Another very important application of diuretic renography is transplant. Donor evaluation is same as like a conventional renogram that I have already showed you. Transplant, what are the most common complications? Immediate post-transplant complications.
Immediate most common complications post-op. In post-op period, maybe ma'am, acute rejection, it may be decreased urine output, acute tubular necrosis, it may be a urinary leak.
Ureteric obstruction.
Ureteric obstruction. There
So
may be.
Now, in a transplant kidney, that kidney is transplanted in the iliac fossa, correct?
Yes.
Yes, ma'am.
When you do a DTPA renogram in these cases, first change that happens is you will acquire it anteriorly.
Camera, yes, the camera is
Because
anterior.
I said normally the kidneys are located posteriorly, so we acquire it posteriorly. But in such cases, transplant in the iliac fossa, the kidney is located anteriorly. If you do posterior acquisition, you will have false figures over here. So here the acquisition happens anteriorly. This is your transplant kidney in your right iliac fossa. So here the blood supply is from your iliac artery, correct?
Yes, ma'am.
So it is not from your abdominal aorta, but once it reaches the iliac artery, whether your perfusion is normal or not. So according to you, whether the perfusion is normal here or abnormal?
Appears normal, ma'am.
Correct. Now, if you look at the curve, whether the curve is normal or abnormal?
Appears normal, ma'am.
Appears normal.
Whether your cortical uptake, your parenchymal function is normal or abnormal?
Perfusion is okay. Uptake also seems, ma'am, Diagnostic 20.
There is a little.
See, the other usually what helps in assessment is your GFR here, correct? If your GFR is 55.2, do you think the function is abnormal?
No, ma'am.
No, ma'am.
So your GFR, if it is 55, your perfusion is normal, your GFR is 55, your curve is normal. So this is a normal functioning transplant kidney in the right iliac fossa, correct?
Yes.
Now, usually it is very important, though we don't do it, is if we have one baseline transplant functional evaluation of the patient, it is very easy to understand how it is over a period of time. In future, if somebody gets any complication like rise in serum creatinine, if we don't have what is the baseline, we can't compare it. Now, if you look at this, what will happen in the acute rejection?
There is thrombosis in the vessel, so the perfusion will decrease.
Correct. So because of your perfusion may be impaired if there is a thrombus. In acute rejection, there is the nephrons do not function, correct? That is why it is not picking up. Your creates start rising immediately after the surgery. Your nephrons are not able to excrete out. Okay, so this is your immediate post-op, which was normal. And if you look at the perfusion, do you see the perfusion like you see in the earlier images? These are perfusion images. No, correct? So your perfusion is compromised. This is your cortical uptake phase. Do you see cortical uptake here? Crossly gone down, correct?
Down. Yes, ma'am.
Characteristic picture of acute rejection. See, for us to tell you, that is why we usually say that if we have a baseline scan, it is easier to compare and then give a diagnosis. If we don't have this baseline, at first scan itself, it is very difficult to say acute rejection. But here, because your perfusion itself is compromised, we can definitely say. Now, next complication you said was acute tubular necrosis. So what happens in ATN?
Microvascular thrombosis leading to decreased perfusion of the nephrons.
See,
and leading to necrosis of
not the entire nephron. As the name suggests, acute tubular necrosis.
Okay.
Correct? It is a tubular necrosis. So that means there are parts of glomerulus. There is a reason why I have showed you all the parts of glomerulus, because there are targeted studies for each part of a glomerulus. Now, if you talk of acute tubular necrosis, it is the tubules which are impaired, correct? Your glomerulus is preserved. Now, if you look at here, your perfusion is normal, correct? Your cortical uptake is normal, but do you see excretion?
No. So
Correct?
because of tubular necrosis.
Excretion is from where? In the tubular part of it.
Tubular.
Because
Yes.
there is tubular necrosis, it is the drainage part of it which is impaired. Most of the times your perfusion is preserved, your cortical uptake is preserved, it is a drainage. If you look at the curve, you will usually get an obstructive type of curve over here. Okay. Now, what is the treatment of ATN? It's a medical management, right? It is not a surgical management. You give those inhibitors, right? Immunity inhibitors, I can't recollect the name. But usually if you repeat the scan after the course of therapy, this is the same patient. Do you see the improvement?
Yes, when excretion is there.
Your curve, which was obstructive pattern, now returns to the normal pattern. So it is if it is an ATN, it is a conservative management. So DTPA renogram or your EC renogram usually has most of the times can give you a correct diagnosis on ATN. Now, third complication, as you mentioned, was what? Urinary leak, correct?
Yes.
Normally, as I have shown you the images, you know from where the tracer goes into the kidneys and into the bladder, correct? Now, this is your transplant kidney. Do you see abnormal activity over here, which is gradually increasing?
Yes, ma'am.
Yes, ma'am.
See, there is a clear pathway which urine follows, correct? Anything outside the pathway is abnormal. So if you have a transplant kidney, your pathway is kidney, ureter and bladder. There has to be no other activity you see. In this case, your bladder is somewhere over here. Your activity which you see over here is accumulation of urine through the leak.
Yes, ma'am.
Okay. Now this is for one of you to read it now. This is from what I taught you before. So one of you who is supposed to answer today can answer now.
Yeah. So this is a.
Now first tell me whether this is DMSA or this is a DTPA.
This is a DTPA scan. DTPA scan because first we can see 3 seconds. So it is a DTPA scan. This is F+20 protocol because last is given as 20 minutes.
F+10.
F+10 protocol.
This is the
DTPA
frame.
scan.
So don't go. These are not the minutes. These are the frames. So this is F+10, F-15, and F+0. These are the only 3 protocols that are followed. This is today's study only. That is why I have put it. So you can read it.
Yeah. So it is a DTPA scan. F+10 protocol. In the initial perfusion images, we can see that the right side kidney shows normal uptake and normal perfusion. Left side kidney shows less delayed perfusion, like less perfusion.
Both kidneys appear to have normal perfusion, I think.
One person answer first, then if there is somebody who wants to add to it, they can add.
Yes. So in the perfusion images, we can see that the left side kidney shows
Please
slight.
remember one thing, on nuclear medicine studies, on your right is right, on your left is left.
Yeah. So this is a DTPA scan F+10 protocol. In the perfusion images, we can see that the left kidney shows a normal perfusion, whereas the right kidney there is a slightly delayed perfusion as compared to the other side. In the parenchymal images, we can see that in the parenchymal images, you can see that the right-sided kidney shows a delayed excretion of the radio tracer. And the whereas the left-sided shows a normal excretion. And we have, yeah. So in the
What does
yeah,
the curve tell you?
so this curve is type 2 obstructed curve.
Right obstructed. How is the function preserved of right kidney or impaired?
Right kidney, it is more than 40, it is 44, so it is still preserved. So it is type 2 obstructed curve, but it's
Yes,
preserved.
you have other parameter GFR, which is 45.
45, so it is more than 40, so it is function preserved, but right sided type 2 obstructed
System is
system.
obstructed, correct?
Yes, ma'am. Yes, ma'am.
So able to read it now?
Yes, ma'am.
Who reads? Who wants to read this?
Yes, ma'am. So yes, ma'am. This is a DTPA scan which is showing in the perfusion images, ma'am. The perfusion appears to be normal on both sides, and thereafter, ma'am, in the excretory images, there is some amount of retention seen on the right side, ma'am. And on the graph, yes, ma'am. So this appears to be a F+10 protocol.
Mine are all F+10, so you can leave the F+10 part. I don't do
Okay,
any other protocol unless there is an indication.
Okay, ma'am. So there is some amount of delayed excretion on the right side. Other than that, ma'am, I feel it is normal. GFR on both sides is 40-40. Split function is 50-50. So both side function is unremarkable. Perfusion is okay. And only some amount of reduced excretion on the right side. Otherwise, unremarkable, ma'am.
So both kidneys normal function, normal drainage.
Yes, ma'am. Yes.
See, many a times, even if there is a slight calcial dilatation, you may see a picture like this, but you should not look at these images. You should look at the first, whether there is retention or there is a clearance of all these things. If there is a clearance, it is a non-obstructive system with preserved function. Curve you should look at, curve is normal. So it is a normal kidney. This was a donor today, which was sent for evaluation to us. So if their GFR is normal, they can take the patient as a donor.
Yes, ma'am.
Unless there is a gross structural abnormality, in spite of preserved function, they may reject it. But if there is no major structural abnormality, function is preserved, the patient qualifies for the donor, unless there are other parameters also for him to pass as a donor. Now, somebody else wants to comment on this. This is the renogram for a change. All those I have shown you before were all DTPA renograms. This is easy renogram. One thing which I would like to mention for you all is whenever you have create values with you, whenever you see the patient, correct? So usually your clinical question is to evaluate obstruction, but the patient has a significantly elevated creatinine value. Although there is no contraindication to the test, even if the creatinine value is 11, but in case your clinical question is obstruction, it is better to do an EC renogram in such patient because the quality of images would be better. Unless your interest is of GFR value, EC renogram will serve your purpose of ruling out the obstruction. Also, it will give you differential function and a rough estimation of GFR, but not a like in DTPA, we comment directly as a GFR value. In EC, we comment you as EC clearance. Okay, so this is an EC renogram. Reading is more or less same as DTPA renogram. There is no difference other than just the year, although it is GFR, but this is the creatinine. Do you see the values 159 and all? 159, 55. These are EC GFR. Okay. So other than that, reading is more or less is the same. Your perfusion, your cortical uptake. So is the system obstructed or a non-obstructed system?
Non-obstructed.
There was bilateral hydronephrosis in this patient. So is there
Left
obstruction?
side there is delayed excretion. Left side there is still
But if
retention
you
of the
look at the curve, it has drained off, correct? If you look here, what is the
Yes.
amount of activity and see, if you have a dilated system, slight amount, mild retention is going to be there because it is not possible to for it to 100% empty after LASIK. So slight amount of retention will be there. But if your retention is less than 30% after LASIK administration, it is a non-obstructed system.
Okay.
If you get a TR of less than 10 minutes, see here, if you look at your
This should
TR,
be 3A curve, 3A curve or no? 3A.
3A, dilated non-obstructive
dilated,
system.
non-obstructed, functional
Yeah,
dilatation
3A
of the
curve.
QC system. So all of you have become nuclear medicine physicians now and can read DTP renograms. Okay, so this was on your applications of nuclear medicine in benign pathologies. So, sir, we have time, or should I cover malignant?
No, you go ahead. No problem.
Okay. So, what are the nuclear medicine investigations you are aware of in malignancies? I think everybody knows FDG PET scan.
Yes, ma'am.
FDG, PSMA, PET scan.
FDG, PSMA, PET scan,
MIBG scan.
MIBG scan,
Bone scan,
Bone scan.
bone
MDP,
scan,
So
MDP.
what are
indium
the modalities that you use for urological malignancies?
For
PSMA
CA
PET,
prostate,
CA
PSMA
prostate,
PET CT for prostate, MIBG for pheochromocytoma,
adrenal, yes, ma'am.
indium, gallium,
Indium,
WBT, indium
Indium
scans
not
for
available
thyroid.
in India.
Okay.
MDP bone scan we do.
See, when you talk of malignancies, we have RCC, which I will, there's no point covering rare malignancies. When you talk of malignancies in urological, most common which you will frequently encounter is your RCC, correct? And your prostate CA, which is the most common malignancy. When you talk of RCC, for evaluation before nephrectomy, you will have a DTP renogram for your assessment of, suppose because you have to knock off one kidney. So what is the baseline kidney function for the patient? If the opposite kidney is normal or abnormal, you will do a DTP renogram. The other application is what are the, you can do an FDG PET scan, although it has a limited role in RCC because FDG is excreted through the kidney. So many times if you have, because the most common, usually the presentation is renal mass. Very difficult to delineate whether, and in close proximity to the calyces, many a time it is, and the concentration also FDG, many a time it is limited. So when you talk of RCC, the FDG role is very, very limited in RCC. Okay. Now I am more focused here on prostate CA because that is something which is new and has much better applications over here in your practice. Okay. Now, when you talk of prostate, the imaging modalities that you use are your transrectal ultrasound, which will give you how your prostate volume, which will help in guiding your prostatic biopsies. But alone, just as USG transrectal ultrasound, it has a very low specificity. Correct? The next modality is CT scan, which has no role in primary tumor staging, usually used in nodal staging because it's a soft tissue. For detection of bone metastasis, it is inferior to a bone scan and an MRI. Okay. Now, MR imaging is the modality of choice for CA prostate because it gives you the local disease status. It helps you in primary tumor staging, which zone of prostate is involved in, because if you want to subject for surgery, although it is limited role in nodal metastasis, and it also has important role in detection of tumor recurrence. Now, when we talk of nuclear medicine investigations in prostate, two major investigations are your radionuclide bone scan and you have PET-CT imaging. Now, when you talk of bone scan, what are the kind of metastasis, bone metastasis in prostate CA? Either they are osteoblastic or they are osteolytic.
Primarily osteoblastic. Osteoclastic function is also there.
It is very important to understand that if your primary in prostate and it is osteoblastic metastasis, that is why a bone scan is helpful, and bone scan is more sensitive for detection of bone metastasis compared to CT, correct? That is why bone scan is the modality of choice. But same thing in RCC, what is the kind of metastasis you have? Even RCC has bone metastasis. So what are the kind of metastasis you have? It is osteolytic. Now, if your osteolytic metastasis does not have an associated osteoblastic rim, your bone scan may be negative. Okay, so in such cases, in osteolytic, in RCC, if you want to do bone scan for metastatic evaluation, your bone scan may be falsely negative. So whenever we advise bone scan, we need to understand that in that malignancy, what is the predominant bone metastasis type. Now in prostate CA, it is a osteoblastic metastasis. That is why a bone scan is very advantageous, because it is osteoblastic. You have an osteosclerotic appearance on radiographs or CT. And like I told you in DTPA, we use physiological agents. So we use something which is called as MDP, which is an analog of hydroxyapatite. Okay. So it gets incorporated, it is a biphosphonate analog. It gets incorporated into the hydroxyapatite crystals and the collagen matrix within the bones. Okay. Now it takes time for MDP to get fixed to your cortex, bony cortex, skeletal cortex. So that is why, like in DMSA, we do imaging after 2 hours. Here, usually we do start imaging only after 2.5 to 3 hours, so that you have MDP fixation onto the bones and there is no background. So your image quality is good. Only thing is bone scan, because as I told you, it is something, any osteoblastic activity will be picked up on a bone scan, correct? So a fracture healing also happens by osteoblasis, correct? So even a fracture will be picked up on this. So any osteoblastic activity will be picked up. Any history of trauma, which may give rise to osteoblastic activity, is going to be picked up on bone scan. So MDP bone scan is a very sensitive modality for detection, but the specificity is, that's why relatively low for that. And if it is in the early stages of bone marrow metastasis, it may be falsely negative here. But although more or less it performs very well in prostate CA. Now this is how a bone scan looks like. Okay, you have anterior images, you have posterior images, your entire skeleton is here. Now I will show you a case, a 75-year-old man who is a diagnosed case of CA prostate with 2 months history of worsening of chest and back pain. Physical examination revealed bone tenderness. Now PSA more than 100. Prostatic biopsy, adeno-CA, Gleason score. Do you see the difference here?
Yes.
This was your normal bone scan. Okay. This is your bone scan. So whatever you see over here are the areas of osteoblastic activity. Now, this is characteristic of extensive osteoblastic metastasis. Okay. This I have already told you. Now, when we come to FDG again, when you come to FDG in prostate CA, as you all know, FDG is excreted in urine, correct? Now, prostate is in very close proximity to the urinary bladder. So, FDG is not able to differentiate many a times. It is difficult to delineate the activity because the FDG in urine is also going to go through the prostatic urethra, correct? So because of limited spatial resolution of the PET CT machine, it is difficult to identify whether it is the prostatic urethra urine or it is a lesion in the prostate. That is why it has a very limited role in CA prostate. Earlier, your PSMA PET scan was not available. So an FDG was used initially and many a times we could identify the focus. But from the time your PSMA PET scan has come, I don't think anybody uses FDG. Okay. Now, what is PSMA?
Prostate specific membrane antigen.
As the name specifies, it is very specific for prostate, correct? Now, like all other nuclear modalities, this also, it images the specific aspects of prostate cancer cellular biology. Now, prostate CA cells shows overexpression of this PSMA antigen, correct? I will go to this. Okay. Now, PSMA is basically your transmembrane protein. Okay. You have an extracellular portion, you have a transmembrane portion, and you have an intracellular portion. Okay. Now, this serves as an antigen to your PSMA, what we use for PSMA scan. So, when we inject gallium PSMA, it gets attached to this extracellular portion. Okay. And as a physiological mechanism, it gets internalized. Once it gets attached to the extracellular domain, it gets internalized into the prostate cancer cell. then it gets stuck there because there cannot be any further metabolism of it. And then you image it, so you will be able to identify wherever there is overexpression of the prostate cancer cells, this PSMA antigen, correct? Now, as the name suggests, it is very specific for prostate cancer, but it has been documented to be present in various other cancers. Now, what are the advantages of this PSMA is it is highly specific and it is expressed on all tumor stages, correct? So whether the patient has a well-differentiated CA or it has gone to a stage of a poorly differentiated tumor, PSMA is usually expressed at all the tumor stages. The level of PSMA expression increases with the increase in progression. Okay. It has a very strong correlation with Gleason score, which is usually mentioned in the histopathology reports. It is strong correlation with the high PSA values. Okay, so if somebody has a low PSA value, you usually anticipate the disease burden, correct? And if somebody has a high PSA value, you have a pre-test anticipation of the disease burden. So the gallium PSMA expression or the detection of disease strongly correlates with even the high serum PSA levels. It is regulated by the androgen receptors, and it is also involved in the development of peace metastasis. Now, when we come to, this I already told you. Okay. Now, this is how a normal gallium PSMA scan looks like. This is the normal physiological distribution of it. You will normally see your lacrimal glands and salivary glands, liver. It gets excreted through your small amount of bowel. Also, you will see primarily kidneys and your bladder. Okay, this is the normal physiological distribution. The advantage over here is even though it is excreted through the urine, but your lesions in the prostate can still be easily identified. Now, this is a healthy volunteer. This is a urinary bladder. This is a normal prostate location. Do you see anything abnormal over here? Nothing. So there is a normal prostate. This is, I have written prostate cancer because this was diagnosed, but if somebody who is, suppose a PSA is only high and was referred for gallium PSA, and if you see this focus in the prostatic bed, this is highly suspicious of the prostatic malignancy. And what is the advantage of diagnosing it is if a targeted biopsy from this site is important, because if you do a biopsy from some other part of the prostate, it is likely that you will get it a negative report. Okay. A guided biopsy from this place will give you the maximum yield. Okay. Now, this is an example. If you see, this is the urinary bladder activity and this is the prostate lesion. Do you can still differentiate, correct? Because it does not, even if it goes through the urine, your activity, the intensity of activity will clearly identify it. You don't need. Now I'll show you why it is important role of it. This is again uptake in the multifocal uptake in the primary, and these are the lymph node metastasis. Now, if you look at this CT scan, you have a 3 millimeter lymph node in your left external iliac region. Now, as per your radiology criteria, you may not call it as abnormal because usually on CT, you have a size criteria of 1 centimeter, correct? This may totally go off as normal on a CT report, but if you look at a gallium PSMA scan, it is not based on the size, but it is based on the PSMA expression of it. If you see the PSMA expression over here, okay, here is a known case of prostate. This is your prostate primary. This is the uptake in the lymph node. So this is metastatic lymph node. So your staging changes. When it was M0 on your CT, it has changed to your M1. Okay. Again, if you see this lymph node here on CT report, this will be regarded as a totally normal lymph node because hardly the size is 2 mm. But if you look on your PSMA scan, it lights up, correct? So it's a metastatic lymph node. Reversal. Okay. Now, if you look at the figures, the sensitivity of a CT scan for lymph node staging and specificity, because this is basically based on size criteria. MRI, again, it has a very low sensitivity and reasonable specificity. But if you look at a PSMA PET scan figures, it has a very good sensitivity as well as a comparable specificity. That is why PSMA PET scan is the modality, has become the modality of choice in patients with prostate CA. Again, if you see here, you have a tiny lymph node, but with that, you also have a skeletal metastasis. You can not only see, but you can also comment. We also comment on seminal vesicle involvement by the prostate CA. The extent of information basically that we can provide on a gallium PSMA scan is extensive, right from the primary tumor, lymph nodes, involvement of seminal vesicles, skeletal involvement, soft tissue involvement in lungs or liver. Basically, it's a one-stop shop for prostate CA. Okay. Now, everybody has heard of this word Theranostics, right? Which is in now. Basically, Theranostic is combination of two words. In Theranostics, Thera comes from therapeutic application and Gnostics comes from the diagnostic application. Now, it does not mean that you have different diagnostic and you have different therapeutic. Theranostics means you have the same agent which can be used for both diagnosis as well as the therapy. Okay, it is one agent. It is not two different agents. Now, when you talk of Theranostics, in prostate, why I'm talking about Theranostics here is because the PSMA has become a theranostic agent today. Now, what is the difference is, suppose this in conventional imaging modality, this is the structural abnormality, but in a functional imaging, this is something which has been picked up, correct? Diagnostic imaging will pick up the diagnostic abnormality. Now, based on this, we will use the same agent, okay, to target only these cells, which are positive only for the target, but it does not hamper the normal cells. Okay. So you have a targeted therapy with the same agent without damaging the normal cells, which if suppose the patient when a prostate CA undergoes a radiotherapy, there will be a destruction or a damage to the normal tissue also, right? Whichever is there in the beam of the radiotherapy will be damaged. Whereas if you talk of a targeted therapy for prostate, it will go only to the lesions which are positive for that agent and it will only give effect and damage only that tissue without causing any damage to the normal tissue or in the field. Okay. So why application is first is by using of diagnosis, it will localize, it will help us understand the biodistribution, that is where the disease is present. And then we use the same agent for its therapeutic application for the treatment, and the same agent can be used to monitor the response also. So you first diagnose, use this patient for targeted therapy. These are follow-up scans. If you see the disease is persistent, then you target it again. If it becomes negative, then you just leave it and then follow it up. This is the concept of Theranostics. Okay. Now, Theranostics for prostate CA is your PSMA is common, correct? Your PSMA is only used for diagnosis and your PSMA is only used for therapy. Only difference is here in diagnostics, your radioisotope was gallium because we wanted to diagnose. In treatment, we use a different agent which is able to deliver higher amount of radiation to those tissues. So there is something called as it is 177 LU, which is lutetium therapy. Okay, which is frequently used now for metastatic castration-resistant prostate CA. This was the difference. Here we use gallium PSMA and here we use lutetium 177 PSMA. So this is your diagnostic image of gallium PSMA. The patient was treated with lutetium and this is a post-treatment image of lutetium. This will also give you an image to understand that it has gone to all those sites wherever the metastatic disease was picked up on the diagnostic scan. Okay. So the biodistribution is again the same. It will get attached to the external extracellular domain, will get internalized, and because of its capacity or ability to deliver high amount of radiation, it will cause the cell death. These are indications, which is okay. This is the normal cycle. This is the therapeutic effect of it. This is the patient with a baseline gallium PSMA scan where you can see the disease in your left supraclavicular region, axial, mediastinal, multiple skeletal lymph nodes. This is after one cycle of lutetium therapy. Okay. If you look at the disease burden over here, and you look at the disease burden over here, has it gone down?
Yes, ma'am. Yes.
See that these are metastatic lesions. Do you see them over here? See the vertebral lesions here. Do you see the vertebral lesions here? You see the pelvic metastasis here. You see the pelvic metastasis here. They have gone down significantly. Although they have not, there is not complete resolution of it, but they have gone down significantly, correct?
Yes.
This is again same. After one cycle, after two cycles, after three cycles, if you see your skeletal lesions, lymph node lesions, all gone. This is again another gallium PSMA at baseline. And you see after 2 cycles of lutetium therapy, all your soft tissue metastases have gone down significantly. See that response. Very extensive skeletal metastatic disease. Although such extensive metastatic disease is not going to get response in 1 or 2 cycles. Usually when we counsel the patient, we counsel for at least 4 cycles to give a demonstrable response on a gallium PSMA scan. This is another example. Only thing that last I want to share is, earlier it was lutetium PSMA, something called as actinium PSMA is now available in India, which was earlier not available. What effect you get in 4 cycles of lutetium? Usually you get in 1 cycle of actinium PSMA therapy. This was the disease burden. This is just after 1 cycle of actinium PSMA therapy. It's called actinium 225. If you see the PSA levels, pre-therapy PSA level was 1301, which just after 1 cycle has reduced to 6.1. So PSA is directly reflective of the disease burden, and if you look at it, gone down significantly. So again, 2 cycles of lutetium, 2 cycles of actinium PSMA. Do you see the marked difference?
Yes.
Yeah, thank you, Suman. It was a fantastic lecture as usual, you know, and the exams are so nearby. I think in 1 week they will be going, so this will be fresh in their mind, and there may be one table for this. Now I have got only one question for you.
Yes, sir.
Many times we come across compromised patients, means where the creatinine is raised, and we cannot do contrast enhanced CT.
Yes,
So
sir.
in such patients, do you advocate if we want to find out whether patient has got abscess or he has got pyelonephritis? And second case is where there is a leakage. Again, the creatinine is raised. We cannot give contrast. So you suggest that in such cases, DMS, I'm guessing, DTPS scan will be better, or
So
DMSS scan will be better?
If your interest is in identification of leakage, your EC renogram in cases of raised serum creatinine would be a better choice, because your creatinine is raised. Depending on what is the level of creatinine. If the creatinine is only 1.52, you can definitely do a DTPA renogram also. But in cases where your serum creatinine is to the level of 5 or 6, an EC renogram will fare better for the indication of leakage.
Right.
But
And
if
at the same,
you get a suspicion of pyelonephritis, then a DMSS scan would be beneficial.
and it has got upper edge than CT scan.
Yes.
In such cases.
Yes, sir.
Okay. At the same time, when we want to diagnose acute renal failure, I mean glomerulonephritis, or after a transplant, again, it is better than biopsy, or biopsy, because
So
many times we are getting confused with the biopsy.
So usually, most of the time, even before if immediate post-op complication, ATN we can definitely say that it is ATN. But most of the times the treatment is started only after they have a histopathological diagnosis that they have ATN. But the features of ATN are very characteristic on renogram. Unless we give a doubtful picture, we definitely can diagnose ATN. Acute rejection, unless that is why I told you we don't have a baseline scan on first scan itself to say it is rejection, because many a times the renal cortex also takes time to. Definitely we can comment on perfusion part of it, so that your vascularity, that means your anatomy of your vascular anastomosis, is preserved. If the perfusion is normal, that we can definitely rule out even on a renogram. But acute rejection becomes very difficult to diagnose only on one scan. But ATN definitely we can diagnose. But as a protocol, I think most of the nephrologists do not start therapy till they have a histopathological diagnosis of rejection or ATN.
Ma'am, I had one question, ma'am. Hello.
Yeah.
Ma'am, how do you, just if an image is given to us, how do you differentiate whether it's a bone scan, a super scan, or a FDG GPET? Like just the skeleton one is given. So how do you distinguish whether it's a bone scan?
See, I have told you, if we are, everything is organ specific. If you see only bones, no soft tissue, it is a bone scan. Okay. You can't tell the tracer whether it is MTP or F18, but definitely you can say it is a bone scan. Correct? Now I have shown you DMSA and DTPA. Can you from the image make out which is DMSA and which is DTPA? Your DTPA renogram will have all the curves, quantitative data, and your images of drainage and everything. Your DMSA will not have anything other than the picture of the kidneys because it is very specific for morphology. So if your DMSA picture is given to you, it is only, you can see only kidneys, no bladder, nothing, no soft tissue, nothing. It is DMSA scan. If you see the bladder, drainage pattern, curves, quantitative data, it is a DTPA or an EC based on what is given over there. So it is a renogram. Okay. Now, FDG has a different biodistribution. Your gallium PSMA has a different biodistribution. If you see strikingly hot kidneys and your lacrimal glands and salivary glands, it is a gallium PSMA scan. If you see, I will show you that image. No, I have. Correct. Do you see this image? And do you see? Although this has metastasis, but this usually you have good lacrimal gland uptake over your salivary gland. It is that usually even in a normal scan, you will have this hot uptake salivary glands and your lacrimal gland. But in an FDG, you will see hot brain. You don't see brain in your gallium PSMA.
FDG will see in the brain. And for super scan, ma'am, super scan
is a type of bone scan which has extensive metastasis. Okay. So if somebody has extensive metastasis where you don't see anything other than the metastasis and your kidney is normal bone scan, you will have kidney uptake also because it is excreted out through the kidneys. So if you don't see kidney, see, this is a bone scan, correct? You see the kidneys because it is excreted out through the kidneys. You have metastasis, but you still see the kidneys. Now, in a scenario where you don't see any body outline, you just see the skeleton with metastasis and your kidneys are also not seen. That is called as a super scan. It is a type of bone scan only. But the disease burden or the metastatic burden is so much that the whole tracer has gone into the metastasis and you don't see anything else. No soft tissue is seen. That is super scan.
Hello, can I ask a question?
Yes.
Yeah, I'm Dr. Chaudhary from Nagpur.
Yes, sir.
Thank you, madam, for your fantastic presentation. I just want to clarify, see, for patients where we decide for nephrectomies, what level you should consider, 10%, 15%, or what is the current concept?
So I think it is more with the surgeons rather than us, but usually in our, in whatever interaction that I had with the doctors out here, they usually take a figure of 10% over here. If their cortical function is less than 10%, they do the nephrectomy rather than the this thing. But it is, I think, more of a subjective phenomenon rather than any specific number given to it.
Okay, thank you.
Dr. Gite?
Sir, one small question on behalf of students to madam.
Yes, sir.
Clinical indications of using the different protocols in the renal scan.
Okay. So normally it is like if kidneys, if the system is dilated, and usually if we want to assess, many times we observe a phenomenon where the system responds to the initial stage of it, but then again it starts getting retention. F-15 we usually use for patients where there is a grossly dilated system. because there are chances that many a times it may still show an obstructive pattern if it is significantly dilated. F plus 0, it's a very subjective kind of thing. There is no specific clinical indication to it other than F minus 15. It's more of a convenience for people like pediatrics. We don't want to inject after F plus 10. So usually many people follow F plus 0 protocol. Based on the workload, if somebody doesn't want to, like F minus 15 we give, when the patient is waiting over there, and then you acquire the renogram in half an hour, the renogram is over. Usually we acquire it at least for half an hour after we inject the Lasix. Because once the Lasix is injected, the peak effect happens at least for that half an hour, we need to acquire the images. So my acquisition time goes on till 40 minutes. If somebody wants to finish it fast, they can give F minus 15 and finish the study in 20 minutes or 30 minutes. So basically there is no specific clinical indication for every protocol. Many like if you see Justlook will follow F minus 10 protocol. I follow F plus 10 protocol, but many places will follow F0 protocol for kids or anything. So there is no specific clinical indication, but in case suppose I found that there is a pattern that we see where the curve initially falls down because of Lasix intervention, but it starts rising again. So that we call it as a delayed decompensation. So in such cases, I usually repeat it with F minus 15 protocol where I get a typical obstructive pattern curve because it is an obstructed system. Other than that, there is no specific clinical indication per se for any protocol.
Okay, thank you, madam.
Thank you.
Madam, one more question.
Yes, sir.
Can these renal scan or for that matter bone scan can be done concurrently with other investigations like CT, MRI, or those have to be spaced out?
So usually they are done on 2 different days because first of all, if you look at the bone scan protocol itself, we inject and the imaging acquisition happens after 3 hours.
Okay.
We have no contraindication that if they have done CT on the same day, we cannot do it. We will be able to do it because in CT, the radiation exposure does not happen. It's like with the machine, but not with the patient. But once we inject bone scan radio tracer to the patient becomes a walking source of radiation exposure. So if we do a bone scan today, usually the radiology department is not going to do CT the same day. However, reverse is possible. If they have done CT before, I can do bone scan. But if I have injected bone first, they will not do a CT scan.
Okay, thank you.
That way, because the patient is a source of radiation exposure even when he is waiting there in the waiting department.
Okay, right.
One more thing. What is the difference between a bone scan and PSMA scan as far as the bones are concerned? Is
the specificity. Bone scan is very sensitive, but the specificity is very poor. Whereas in gallium PSMA, it is specific for prostate CA. So if we are looking at it depends on PSMA scan will also give you about the soft tissue metastasis. If there are any lymph node metastasis or if there are any lung metastasis or soft tissue metastasis are there or not. But a bone scan is purely going to give you a bone metastasis. Although there is no difference in the number of bone lesions that are detected on the scan.
But if we want to find out a very early stage, then the bone scan is better or
PSMA scan is better.
PSMA scan.
Because the PSMA scan will be able to identify even the bone metastasis at a bone marrow stage, not the cortical stage. Even at the bone marrow stage, if there is a metastatic, it will be able to pick it up.
So bone scan is more for the cortical, it starts.
Because
so
what we inject is getting incorporated in the hydroxyapatite crystals which are present in the cortex, bony cortex. It does not detect the marrow metastasis. So once in the initial stage, when the bone metastasis starts from the marrow stage, a PSMA scan will still be positive.
So this is a very important point for the students for their exams.
Yes, sir.
Yeah.
So DTP, sorry, MDP bone scan and fluoride bone scan. So is fluoride bone solve this problem what we are discussing now over the MDP scan?
There is also called as a fluoride PSMA also is available.
Yeah, that's true.
So you can, rather than a fluoride PET bone scan, you can do a fluoride PSMA scan.
Agreed, ma'am.
So that You can solve the purpose. It's basically the cost difference is too much. So if somebody is not very affording, bone scan serves as a good marker to rule out bone metastasis. However, if somebody is affording, either you can do a fluoride PSMA or a gallium PSMA scan, and the patient is already a diagnosed case of. Because money constraints are a major issues for most of the patients here. So bone scans, usually the first site of metastasis in prostate CA is bones. So bone scan, it can serve a good purpose for that because it is very sensitive. In case we pick up something suspicious, further radiological modalities may be done for only that site.
Agreed, ma'am.
So the chances of bone scan being falsely negative are relatively less in prostate CA because they are predominantly osteoblastic. So bone scan is a good marker for that.
Madam, still for the local staging, I think MRI is better than this PSMA
Yes, so
scan.
I have not spoken role of nuclear medicine in local staging. MRI still serves as the agent, the modality of choice for the primary tumor localization.
Okay.
See, because what zone of prostate is involved? What is the local infiltration, whether there is infiltration of the anterior wall of rectum or the posterior wall of urinary bladder. See, all these things are usually very clear on an MRI, although we can definitely see on a gallium PSMA because the CT component is still there. But the sensitivity wise, the MRI is the agent of choice for primary tumor localization and the local infiltration. Whereas if you look for nodal metastasis and distant metastasis, gallium PSMA is the agent of choice because your metastatic lesions are picked up at a much earlier stage compared to the other modalities.
Yeah.
Okay. If there are no other questions, then we can stop here. Dr. Gite, will you like to just say a few words for this presentation?
Yeah, yes, sir. So as usual, madam has done an excellent thing about the student because this is on the view of examination. Just within a week or two, there is exam and a number of questions related to the radionuclides role in urology we usually asked as we are examiner. So there may be they may ask about the PSMA PET scan, they may ask about the FDG PET scan, they may ask about bone scan, they may definitely ask about the DTPA, DMSA, because usually every student will get one or other questions related to this topic. And madam has very transparently and clearly explained everything in details about the topic. So thank you very much, madam, for giving the time and explaining the things.
Sirs will be able to ask more questions and the students will be able to answer properly now.
Good thing.
Thank you so
Yeah.
much.
Okay. Thank you. Thanks to
I
all.
hope the students benefited from it. I
Yes,
have tried
ma'am.
to
Thank
be
you so
as
much.
Yes, ma'am.
simple as
Thank you so
possible
much, ma'am.
in
Thank you so
my
much.
explanation of scans.
Yes, ma'am.
It was excellent, ma'am. Thank you so much.
Thank you so much.
Yeah.
Okay.
I'll stop sharing some now.
Yeah, sure. Okay.
Thank you and good night, everybody.
Good night, everybody.
Good night,
Yeah.
sir.
Good night,
sir. Thank you
teachers.
so much.
Good night.
Good night, teachers. Thank you so much.
Thank you.